Assalamualaikum warahmatullahi wabarakatuh and a very good evening to everyone. Your Excellencies, Professors, Doctors, ladies and gentlemen. It is an honor for me to be the moderator for this conference. I am Noor and on behalf of the organizing committee, once again, welcome to MHS Conference concurrent session. We greatly appreciate your valuable time and participation on this event. And once again, thank you very much for the support. We hope you will learn a lot from this program as we have a lot of interesting topics awaiting for us. Throughout the concurrent session, we will be having oral presentations joining by 10 speakers across different fields of study. With such high numbers, we are anticipating a really exciting presentation by each speaker. We hope all speakers can compete in a healthy manner. To begin this session, I am pleased to introduce our honorable judges for the day. First, we have Professor Datuk Dr. Omar bin Ismail as the Chief Judge, Dr. Lee E. Lee as the Second Judge. All the judges' decisions are final and individual marks will not be disclosed. Without further ado, let's please welcome our first speaker, Hazirah binti Abdul Radzak, with the presentation title Knowledge, Attitude and Practice Towards COVID-19 in Malaysia.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh and very good afternoon to all the judges and the participants for this conference. Today, I'm Hazirah binti Abdul Radzak who would like to present my research finding entitled Knowledge, Attitudes and Practices Towards COVID-19 among Public in Malaysia. For this presentation, I will explain about the introduction, objective, methodology, result, discussion, and lastly is a conclusion. So as for introduction, coronavirus disease, or known as COVID-19, is an infectious disease caused by a newly discovered coronavirus. COVID-19 was originated at Wuhan, city of China. This virus is highly contagious and the incubation period ranges between 2 to 14 days. The major clinical symptoms of this disease are fever, non-productive cough, fatigue, malaise, and breathlessness. Older people and patients with underlying medical conditions such as cardiovascular disease, diabetes, chronic respiratory disease, and cancer are the risk factors of developing severe COVID-19. The transmission of COVID-19 can occur by direct contact with infected people through small respiratory droplets during talking, sneezing, and coughing. However, several precaution steps can be taken to prevent from COVID infection by washing hands with soap or hand sanitizer, practice 1 meter social distancing, and wearing face masks. Next objective. The general objective of this study is to investigate the knowledge, attitudes, and practices towards COVID-19 among public in Malaysia. Meanwhile, the specific objectives are to measure knowledge, attitude, and practices level towards COVID-19 among public in Malaysia, as well as to correlate the demographic and KAP towards COVID-19 among Malaysia. For the methodology of this study, this is a cross-sectional study based on structured questionnaire. The sample size used for this study is 419 respondents. Malaysian with age 18 years old and above is the inclusion criteria of study participant. The questionnaire was adopted from previous study and was constructed using Google Form. Then, the questionnaire was distributed to the public through various platforms such as email, WhatsApp, Facebook, and Telegram. The data obtained was analyzed by using SPSS software, t-test, and one-way ANOVA used to determine the significant difference of mean score, while chi-square used to determine the association of demographic and KAP. P-value less than 0.05 was considered as significant. Next, we move to the result and discussion for this study. This is the information of respondent for this study. As we can see in the first pie chart, the most of the study respondent are female, which is 57.3%. In the second pie chart, the Malays are majority of study respondent in this study, which is 94.3%. In the third pie chart, 40.6% of study respondents are from the people with the age group 18 to 29 years old. In the fourth pie chart, you can see here, most of the study respondents, which is 57.5%, are married. As we can see in the fifth pie chart, bachelor's degree are the majority of respondents in this study, which is 47.3%. In the sixth pie chart, 49.6% of study respondents are employed. In the seventh pie chart, most of respondents in this study are from urban area, which is 69.2%. And in the eighth pie chart, majority of study respondents, which is 32%, are staying in the southern region of Malaysia. The present study shows that there is a statistically significant difference of knowledge between Malays and Chinese, as well as there is a statistically significant association between knowledge and races. The study found that Malay people have better knowledge as compared to Chinese. It is postulated that some of Chinese do not understand Malay and English languages written in the questionnaire. For attitudes result, the present study shows that there is a statistically significant difference of attitude between age groups, marital status, and occupation. It is also shows that there is statistically significant association between attitudes and age group, marital status, and occupation. The present study demonstrated that people with age more than 60 years old have positive attitudes towards COVID-19. It is due to this group of people got high knowledge score, which indicated good understanding about COVID-19 and thus lead to good attitudes towards COVID-19. The findings was contradicted from the study conducted by Ha et al. In 2020, which the study showed that the people with age group 13 to 40 years old have positive attitude as compared to people with more than 60 years old. It also found that positive attitudes are higher among those who are working and retired. The finding was similar and consistent with the study performed by Azlan et al. In 2020. Female in the study showed better attitudes towards COVID-19 than male. The result also comparable with the study performed by Zhu et al. In 2021. For the practices result, as we can see here, there is a statistically significant difference of practices between gender, education levels, and regional. And it also shows the statistically significant association between practices and education levels as well as regional. So it shows that the people with bachelor's degree have a good practices because the higher level education, the better the practices. So it indicates the good understanding of COVID-19 among the people with the bachelor's degree. For conclusion for this study, the study findings suggested that actually the most Malaysians have a good knowledge and good practice in reacting to COVID-19 outbreak. However, Malaysians have a moderate attitudes towards the COVID-19. The higher of knowledge is the better practice towards COVID-19 among Malaysians. Therefore, continuous health education programs by Ministry of Health and strong justification on every strategy to contain COVID-19 should be given by the government to improve the attitudes level of Malaysians towards COVID-19. That's all. Thank you.
Thank you for the very compelling and visually stunning presentation. Now, I would like to invite our judges and speakers for the Q&A session. Please open your camera and microphone.
Alright, congratulations for the good findings. Just asking, because from your result, you said most of respondents have positive attitudes towards COVID-19, but the percentage is 57.5%, which I think not so good. If you are rating, this is like below 60%. So what is your comment? What is your comment?
Okay, thank you for the question, judges.
Can you hear, Hazirah?
Can you hear me? I can hear your question. Can you hear my voice, Prof? Datuk? Can you hear my voice?
Yeah, I can hear.
Okay. So regarding the findings, you can see the percentage is 50 something, right? It's not achieve 60%, right? So because when we compare to the previous study, it shows that previous study shows that the practice percentage for the Malaysian is around 30%. So when we compare with our study, it shows that 50 something. So that's why I come up with the conclusion that Malaysian in 2021, the practices towards COVID-19 is much better as compared to the finding from the previous study.
Thank you, Hazirah, for the wonderful presentation. It is interesting to note that, in your findings, it shows that Malaysians have good knowledge, but moderate attitudes with good practices in reacting to COVID-19 pandemic. In your opinion, do you think Malaysians will continue to adhere to SOPs, or we may become SOP and pandemic fatigue?
Thank you for the question. So I think that yes, it's actually I think that if the government, our government, can give a strong justification why they do a various strategy to curb the speed of the COVID-19 infections, right? So I think it slowly can be accepted by the Malaysian Malaysian why we have to do this kind of the strategy. So now we think that all this strategy is like to is we have no freedom like right now. So if the government can give a explanation on all this strategy, so I know that we now are very fatigued with all the SOP, right? And some of us now is start to neglecting the SOP. But if we Ministry of Health and the cooperation with the government can give awareness campaign. So I think the Malaysian can accept and try their best to comply with SOP, and we try to accept the fact and try to together to fight with this COVID-19 infection. This is my opinion.
Thank you to speaker for the very compelling and visually stunning presentation. It was a pleasure to have you with us. Next, let me introduce our second speaker, Dr. Nuruddin Mohammed Noor, with the presentation titled Knowledge Towards COVID-19 Vaccine in Malaysia. Please welcome Dr. Nuruddin Mohammed Noor.
Hi, Assalamualaikum and good afternoon. I am Dr. Nuruddin Mohammed Noor, who will be presenting knowledge towards COVID-19 vaccination among Malaysians. Contents are introduction, methodology, results, discussion, conclusion. Introduction. On 2019, COVID-19 spreads from China. Then it spreads to the different countries and different populations. On 11th of March 2020, WHO World Health Organization declared pandemic. Then 2020, 18 March, Malaysian government declared movement control order. Then the importance of vaccination came in. Malaysia started first vaccination on 24th of February 2021. Now 13 million people have been vaccinated. There are 5 brands of vaccines used by the Malaysian government. Types of vaccines mainly live attenuated vaccines, inactivated vaccines, unit vaccines, toxic vaccines, and DNA RNA vaccines. Effects of vaccines mainly vaccine acts by immunity stimulation and antibody production. And there are 3 phases of vaccination, and there are different beliefs on vaccine. Objective. General objective to study the knowledge towards COVID-19 vaccination among Malaysian citizens. There are 4 specific objectives: to assess the knowledge about the production and uses, effects, implementation, religious view and beliefs regarding the COVID-19 vaccine among the Malaysian population. Non-hepatitis to test is the knowledge towards COVID-19 vaccination among Malaysian citizens is good. And specific objective, production and uses, effects, implementation, religious view and belief regarding the COVID-19 vaccine among the population of Malaysia is good. Alternate hypothesis, we will see that it is opposite, that is poor. If you look at the bubble chart, there are 4 specific objectives. If you look at the production uses, we'll ask about the efficacy, brands, mechanism, actions, such as the implementation, sources of the information, immunization program. Methodology, inclusion criteria, is the Malaysian citizen age 18 and above and have not received COVID-19 vaccine. Exclusion criteria, non-Malaysian age under 18 and already received the COVID-19 vaccine. This is a prospective cross-sectional study based on the structural questionnaire and involved 700 samples from 1st May 2021 to 30th June 2021. And we have used the standard formula for the calculation of the sample size. Research tool is the questionnaire via the Google form, and it is spreaded or distributed by the WhatsApp, Telegram, and Facebook, other social media. We have done the data analysis by spaces package version 26, and we have done t-test on Gray and Nova, Williams Herbal test, and likelihood ratio. Results, if you look at the demographic data, the female respondents are more than the male. Female respondents 57.6%. So such as after the other contributors maximum 34%, then the CADA respondents is high. The ethnicity, you can see the Malay respondents is the highest, that is 88.9%, and Muslim is 90.4%. Age group, 18 to 25 age group is 59%. Level of education, bachelor degree and above 65.3%. Marital status, the single, the respondent the highest 60.6%. Monthly income, the 50% of the respondents are unemployed. Statistical analysis, we divide the 15 questions into 4 specific objectives. Suppose if you ask about implementation, you ask about the knowledge about registration and about the national immunization program, knowledge about the phases, knowledge about the doses. These are the questions we have asked. So we have divided the respondents into the 3 categories: good knowledge, moderate knowledge, and poor knowledge. If the respondent answer 11 to 15 questions yes, then it is good knowledge. So this is 87%. Such as the 6 to 10 question yes, that is the moderate knowledge, 0 to 5 poor knowledge. Non-significance value, we find that there is no significant difference in knowledge between the genders, between the state residents, between the different ethnicities, between the monthly income groups, and between the marital status. Then we have done the association test, the chi-square test, and likelihood ratio test, and we found no significant association between the male and female, between the different state residents, between the ethnicity, between the religions, between the age groups, between the monthly income, between the marital status. significant value and association, we found that when you have done the ANOVA test, we found that there is a significant difference between the Sikh and Muslim, Sikh and Hindu. And age group, we have found a significant value between the 18 to 25 and 26 to 35 and 46 to 55. There is a significant difference in knowledge. And education level, we have seen the respondent with the diploma and the question with the bachelor degree and above has a significant difference. Then we have done the chi-square test to see the association, and we have found that there is a significant association between the knowledge and level of education about the COVID-19 vaccine. Discussion. The percentage of respondents with good knowledge on COVID-19 vaccination is very high, 87%. This percentage shows that most of the Malaysians have good knowledge on COVID-19 vaccination, similar results with other studies done in this year. In this study, the result is dominated mainly by the Malays, Muslims, female youth with age between 18 to 25. So this classes has the dominant part in the respondents. The significant values of that are demonstrated by the ANOVA test are the difference of knowledge based on the educational level, age group, religion. And the only association that has a significant value, we have found that the association between the knowledge and educational level. And in this study, we found that respondents with the bachelor degree and above have higher knowledge level compared to the lower educational level. Study biasness and limitations. There is some biasness and limitations. The different classes in our findings, certain classes dominating the number of respondents. Biasness in ethnicity, knowledge is the maximum. And biasness in religion, Muslim has the maximum respondents. The study limitation, sample size and distribution, moderate sample size and unequal distribution. The study limitation, randomness and study period, low randomness and short study period. Conclusion, I'd like to say the study showed that overall Malaysians have good knowledge on the production, uses, effect, implementation, and religious view about the COVID-19 vaccination. Even though the knowledge towards the vaccine is in some extent depends on the age, educational background, and religious belief of the population, gender, ethnicity, state of origin, monthly income did not influence knowledge. The younger generation has the good knowledge about the vaccination over the older one. Bachelor degree and above education has the better knowledge, which show the importance of education in implementation of vaccination program. Biasness and limitations of the study makes the results skewed towards the different classes. Perhaps large number of population, equal distribution of sample with longer period of study would reflect the better results on the knowledge towards the vaccine among the Malaysian population. These are my references. Thank you very much for listening this presentation. This is my team. I am the principal investigator. My co-investigators are Muhammad Aiman Naim, Muhammad Nasiruddin, Aizatul Nuha, Afzahnani, binti Muhammad Noor, Noor Maisara, and Daniel bin Majzaki. Thank you very much.
And colorful presentation we had just now. I hope all of you enjoyed this amazing presentation. Now, we welcome once again the speaker to answer questions by the judges.
Nuruddin, thank you very much for the good finding despite a short period of study. Whether the knowledge of vaccination's benefit is translated into receiving early vaccination, is there any association?
Pardon, Dato?
No, whether the good knowledge of benefit of what I call vaccination translated into their practice of getting appointment to get early vaccination among the respondents.
Among the respondents, we have seen that the age group, that is 18 to 25, has the good knowledge about the vaccine and the effects and safety than the others. But the government opened at first for the phase 1 for the frontliner, and now government is in the phase 2. So I think now accelerated vaccination, we can see the most of the in Kedah 1.2 million people already get the vaccine, and every day more than 500,000 people getting vaccinated. So it's accelerated actually because the government is going towards the from the adult towards the younger one. So I think hopefully we can get the accelerated vaccination because of the knowledge, because the first the older generation, the knowledge is towards the vaccine and its effects and religious view is poor than the younger one. So at first it was slow, now it's faster because it's going towards the open for all actually, more than it.
Thank you, Dr. Nuruddin, for the wonderful presentation. I would like to ask regarding methodology as regards to the questionnaire that was developed. Was it a pre-tested questions or was it developed by the group?
It was developed by team. Actually, two teams worked together to Dr. Rahman and team together. We develop a questionnaire and we test pilot test first. We did the pilot test among the near about 20 to 40. Then we make the rectification, and not only that, we look at the previous study also because there are some similar studies. So we try to avoid the collision between some of the findings before also.
Thank you.
Thank you, judges and speaker, for the wonderful presentation and session. Moving right along, I will introduce our third speaker, presenting on a very important topic, attitude and acceptance towards COVID-19 vaccine in Malaysia. Please welcome Professor Madya Dr. Harif Fadzilah binti Hashim.
Assalamualaikum and salam sejahtera. First of all, thanks to all group members for their contribution in conducting this research project. Our research topic is the attitude and acceptance towards COVID-19 vaccination in Malaysia. As of 25th July 2021, Malaysia has recorded over 1 million COVID-19 cases with nearly 8,000 deaths. According to the Centers for Disease Control (CDC), vaccines are one of the most effective ways to safeguard us from COVID-19. The main reason for choosing this topic are: first, Malaysia has embarked on the national COVID-19 vaccination program since 24 February this year. However, significant numbers of the population fail to turn up for COVID-19 vaccination, as shown by a study in Kelantan. Second, there are anti-vaccine groups on social media giving misleading information regarding vaccination. Few countries had conducted surveys this year to assess the acceptance and hesitancy toward COVID-19 vaccination. In Malaysia, Syed Alwi and Wek Hefi had conducted similar studies regarding the acceptance and attitudes of Malaysians toward COVID-19 vaccination. The figure shows various factors related to the attitudes and acceptance of COVID-19 vaccination. For example, the acceptance of COVID-19 vaccination is related to worries about the unforeseen effect, doubt of the vaccine effectiveness, religious belief, and preference for natural immunity, while the attitude associated with do not have enough information about the vaccine, preference for natural immunization, and ignorance towards recent update on vaccine. The objective of our study is to explore the attitude and acceptance of Malaysian population towards COVID-19 vaccination. The study design of our research is descriptive and cross-sectional, conducted from 7 May 2021 to 28 May 2021. The Malaysian population as estimated in 2021 was 32.7 million. Our sampling method is confident random sampling involving a person aged 18 to 65 years old. Using the formula, the minimum sample size needed is 700. The number of responses received from Malaysian citizens are 700. We distribute the questionnaire through the online Google form through social media such as WhatsApp, Facebook, Instagram, Telegram, and Twitter. We use dual languages, which are Malay and English, to make it more understandable for all Malaysian citizens. The data were collected and analyzed using SPSS software version 26. One-way ANOVA and chi-square tests are used to determine the differences and relationship of the parameters in the study. The p-value is significant if it is 0.05 or less. We use the following terminologies in our study. First, a good attitude means the participant believes that the vaccine is safe and essential to eradicate the COVID-19 virus and looking forward to getting vaccinated and also encouraging others. Second, a bad attitude means the participant believes that the vaccine is dangerous and ineffective, refuses to get vaccinated, and does not encourage others. Acceptance means the respondent's willingness to accept the COVID-19 vaccine. Among the reasons for acceptance are to increase the immune system, obtain herd immunity, prevent the virus from the spread in the country, and to follow the instruction from government. Reject means the respondent is not willing to receive COVID-19 vaccine. The results show that 58% of respondents are female and almost 60% are in the age group of 18 to 25 years. Only 4% of respondents are over 56 years old. The figures show that 41% of respondents are from Northern Peninsula, followed by 22% from East Coast. Only 4.7% are from East Malaysia. Almost 90% of respondents are Malay, only 2% of respondents are Chinese. These figures show that 91% of respondents are Muslim, Buddhist and Christian only constitute 2% and 1% respectively. 60% of respondents are single compared to 35% married respondents. These figures show that 65.5% of respondents have graduate and postgraduate degrees, followed by 23.2% respondents have diplomas or vocational qualification. Half of the respondents are not working compared to 21% in B40 and 21% other group. Only 58% respondents have good attitude toward vaccination. Reasons for rejecting COVID-19 vaccination are mainly regarding worries about unforeseen effect 20.28%, followed by effectiveness of the vaccine 15.5% and wait and see 12.3%. 568 respondents accept vaccine. The main reason for willingness to accept COVID-19 vaccines are the vaccine increases the immune system to obtain herd immunity to prevent the virus from spread in the country and following the instruction from government. One-way ANOVA test showed that there was a significant difference of attitude among groups of gender, religion, ethnic, level of education, monthly income, marital status, and age group of respondents. However, no significant difference in attitude is noted among religious groups. Chi-square test showed that there was a significant association between attitude and gender, region, ethnic, level of education, income, marital status, and age group of respondents. However, no significant association is noted between attitude and religious group. Chi-square test also showed that there was a significant association between acceptance and gender, region, level of education, monthly income, and marital status of respondents. Malaysia has a high acceptance rate, 81%, toward the COVID-19 vaccine. Only 19% of Malaysian adults reject vaccine. The result was similar to a study by Syed Alwi conducted on December 23, 29, 2020, recorded 83% acceptance rate in Malaysia. And other study also recorded a 72% acceptance rate in Penang population. However, this study found that only 58% had good attitude, while the other 42% had a bad attitude toward COVID-19 vaccine. It does not tally with the high acceptance rate. Probably the question were not enough to reflect the actual situation. This study showed the mentality of Malaysians who are worried too much but agreed in the end. We collected a limited sample size from religious and ethnic groups. Online data collection, which means we may not have reached vulnerable groups such as socio-economic background and those who are illiterate. A more significant percentage of the respondents were from a single geographic area, that means Northern Peninsula, which may impact the generalization of the survey result. Attitude toward the COVID-19 vaccine were not very convincing, when the study found that only 58% had a good attitude, while the other 42% had a bad attitude. This is an urgent need to counter misinformation and provide accurate and reliable information. The study also found that 81% Malaysians are willing to accept vaccine and only 90% reject vaccine. The reason for rejecting were mistrust, understanding of risk and how immunization works, and influenced by information spread through multiple media channels. This has no association with religious belief. Strategy to build good attitude toward vaccine and acceptance rate should directly address community-specific concern or misconception. Therefore, this study will help government and public health officials develop a proper strategy and efficiently deliver public health messages. With that, I thank you very much for your kind attention.
Thank you, Speaker. I am pleased to hear an excellent progress among Malaysians towards the acceptance of COVID-19 vaccines. Without wasting much time, I welcome the judges once again for the Q&A session.
Prof. Harif, is there any explanation why there's a lot of rejection initially from the people in the northern territory like Kedah and Kelantan as compared to the south as well as central Klang Valley?
Thank you, Datuk, for your question. Actually, if we can see from the study, the majority of the respondents are from northern and middle region compared with East Malaysia and southern part of Malaysia. The main reason for rejection of the vaccine mainly because the participants are worried about the what we call the unforeseen effect, the effect of vaccine in the long term, and they also worried about the vaccine whether it is really effective or not. And some of the respondents they just want to wait and see what happens to the others who have vaccine. And these are the three main reasons why they wait and see, not accepting the vaccine. However, lately we noticed that the acceptance rate of the vaccine improved. This one maybe after we can see from mass media, various efforts have been taken by the government, open the PV centers at the community level. So it's open the mind of the public regarding the vaccine. So I think that now the acceptance will be more better compared to previously.
Thank you, Dr. Harif, for the wonderful presentation. It is commendable to note that within a span of 3 weeks, the research team was able to recruit close to 700 respondents. So that is something very wonderful actually within a span of 3 weeks. My question is that how how would this particular study add to the body of knowledge, since there was already a published paper by Said Alwi back in 2020 December? How would this differ from the previous publication? Thank you.
As we noted earlier, in Malaysia, there are only two studies lah. One done by Said Alwi, that one responded from throughout Malaysia, and the other study from McAfee, mainly Penang. So in our study, we go into detail lah, the reason why the participant reject the vaccine. Top worry about the unforeseen effect, effectiveness, and the lower one about preference for natural immunity. There might be that question is slightly different from other study lah. We go into deeper, what the main reason why the participant not keen for vaccination. I think that part lah, different. We look into different aspect of perception of the participant compared with other studies. I think this can be add on to the public lah, so that those involved in conducting higher education can focus more on this reason.
Thank you, judges. I hope the speaker has answered each question very well. The next speaker will be Professor Madya Dr. Samina binti Muhammad Qasim on the topic mental health status in Kota Serta District.
Assalamualaikum warahmatullahi wabarakatuh. Good afternoon. My topic is mental health status among UniSHAMS students and staff during COVID-19. I'm Azimah binti Norbidin from UniSHAMS. As for introduction, stress, anxiety, and depression have all increased as a result of COVID-19 outbreak. According to WHO, mental health is defined as a state of well-being in which every individual realizes his or her own potential, can cope with the normal stress of life, and able to make contribution to his or her community. PDRM state that total of 1,738 suicide cases were recorded from 2019 to May 2021. A study done by Mohammed et al. At 2020 found that COVID-19 has declined individuals' mental health. So, for general objective, to study mental health effect during COVID-19 among UniSHAMS students and staff, specific objective to assess depression level among UniSHAMS students and staff during COVID-19, to determine stress level among UniSHAMS students and staff during COVID-19, and to evaluate anxiety level among UniSHAMS students and staff during COVID-19. Literature review. Mental health in Malaysia. Common mental health issues among Malaysians are associated with depression, anxiety, and stress. This is one of the leading causes of disability and health loss. Mental illness is expected to be the second highest health problem after heart disease by the year 2020. Mental health among students keep rising every year. This is a graph showing prevalence of mental health issues in Malaysia as of June 2019. From the summary, you can see that increasing prevalence of mental health issues among Malaysians during COVID-19 outbreak. So for methodology, first is the study design. First, prospective descriptive. Second, cross-sectional. And third, analytical study. Sample size and sampling method. For student and staff, we have selected 333 students and staff from UniSHAMS. Age group, above 18 years old. The groups are divided into several such as 18 to 25, 26 to 33, 34 to 41, 42 to 49, and 50 years old and above. Our main focus are three: first, age group; second, gender; and third, education level. Research tools and materials. Depression, Anxiety, and Stress Scale, DAS-21, is a set of 3 self-report scales designed to measure the emotional states of depression, anxiety, and stress. These DAS-21 questions are based on guidelines by the Ministry of Health of Malaysia. Questionnaires were distributed by using Google Forms, and we have used Microsoft Excel and SPSS software to analyze the result. For data collection, durations are completed in 2 weeks. Main elements, there are 3 mental health elements in DAS 21 inventory, that is depression, anxiety, and stress. Scoring for DAS 21 tests, normal, low, moderate, severe, and very severe. As for the results, there are 4 variable definitions that we use. First, age groups, 18 to 25, 26 to 33, 34 to 41, 42 to 49, and 50 years old and above. Highest education, gender, male or female, and student or staff of UniSHAMS. So for related analysis, age group versus stress level. For stress level, age group 18 to 25 are the most. They are the most of our respondents, so the result is severe. Age group versus anxiety level. For this age group, 18 to 25 are the most severe in terms of anxiety level. Age group versus depression level. Age group 18 to 25 years old. Again, they are severe in terms of depression level compared to other age groups. Relationship between independent with dependent variable. Independent variables are gender and age groups, while dependent variables are depression level, anxiety level, and stress level. So for relationship between gender and depression level, there is significant relationship between gender and depression level. P equals to 0.000. Females are more likely to have abnormal depression level at 72.1% compared to males at 27.9%. Relationship between gender and anxiety level. There is significant relationship between gender and anxiety level. P equals to 0.002. Females are more likely to have abnormal anxiety level, 69.8% compared to males. Relationship between gender and stress level. There is significant relationship between gender and stress level. P equals to 0.002. Females are more likely to have abnormal stress level at 71.2% compared to males 28.8%. Relationship between age group and depression level. There is significant relationship between age groups and depression levels. P equals to 0.000. Age group between 18 to 25 are more likely to have abnormal depression level at 78.8% compared to others. Relationship between age group and anxiety level. There is significant relationship between age groups and anxiety levels. P equals to 0.000. Age group between 18 to 25 are more likely to have abnormal anxiety level at 77.9%. Relationship between age group and stress level. There is significant relationship between age groups and stress levels. P equals to 0.000. Age group between 18 to 25 are more likely to have abnormal anxiety level at 80.4% compared to other age group. As for discussion, we can see that for levels of stress, anxiety, and depression among our samples, majority are severely depressed. For depression at 68%, severely anxiety at 58%, and for stress, severely stressed at 38%. For conclusion, students are more prone to have abnormal mental health level compared to staff of UniSHAMS. Higher socioeconomic class tend to have less mental issues compared to low socioeconomic class. And as for recommendation, we recommend to increase sample size to better represent the total population, longer period of time to obtain more reliable and precise test finding, identify factors which can lead to anxiety, depression, and stress among students, such as online distance learning, poor internet connection, study environment at home, tasks at home such as cooking, tutoring, and babysitting younger siblings, and more, which can contribute to prolonged mental health issues. We also recommend to provide counseling and support system to students, which is always available for them to reach out, especially at the university level through mentors and peer support. This is my references. Thank you.
Thank you, speaker. I appreciate the remarks you made on this topic. I wish that more people would try to see all sides of the issues that come up due to COVID-19. For now, we will proceed for the Q&A session. Please welcome the judges.
Azimah, for the good outcome research in a short 2 weeks period study.
Yes, thank you, Dato'.
What percentage of your respondents, student, as compared to staff? Because this is university, I think I suspect more students as compared to staff.
Students are around 120, for total students, we have 4,309, total staff is 402, but we haven't break down the total students from here. But as for the samples, mostly are from students lah, Dato'.
So that's why we see more what you call highest incident in a student, because I mean the numbers are not similar. I mean the number of student and number of staff is not equal.
Yeah, they are way apart.
So difficult to make conclusion in terms who are more stressed, staff or students.
We need to make another group which is only staff and the other group is only students, so we know. But most likely, the one from the result, we can know that the staff is less stress, anxiety and depression compared to students lah.
Among the students, do we know from which Kulliyyah they are coming from? Well, medical versus others?
No, Dato', we keep it anonymous.
So whether the medical students are well prepared as compared to the non-medical students.
So maybe in next research, we can find out on that.
Right. I mean, there are so many other things that we can uncover if we can do more, what we call, recruit more students and probably more staff as well.
Yes, Dato'.
Well done, well done.
Thank you, Dato'.
Azimah,
Thank
for
you,
the
Dato'.
nice presentation. Well, my question is, why do you think females showed higher prevalence of mental health illness as compared to the male respondents?
Okay, thank you, Doctor. Okay, as from my opinion, I think because the nature of the women are usually multitasking and women tend to think a lot compared to men. So I think the prevalence are shown more to female as compared to male because women are complicated as we know the nature of us. I hope it answers you, Dr. Lee. Thank you.
Compare what you call what happened to the what you call public outside university setting. Whether
Yes.
maybe if the funding are similar, then we can generalize whether in university environment or outside university, female are generally more sensitive or more.
Good suggestion, Datuk. Maybe in the future we can take that into consideration. Thank you, Datuk.
Alright, thank you, speaker, for answering those questions and for the great presentation. Now, let us please welcome our final speaker for the day, Professor Dr. Ropilah binti Abdul Rahman, with their presentation topic, The Eye in COVID-19. What do we know?
Assalamualaikum warahmatullahi wabarakatuh. A very good afternoon to everyone. With the never-ending, ongoing pandemic, I'm sure COVID-19 is on everybody's mind. But what do you know about the eye? Allow me to share what is known so far. First emerged in 2019, COVID-19 is caused by a novel beta corona RNA virus, which cause severe acute respiratory syndrome 2. The typical clinical symptoms include loss of taste, anosmia, chills and rigor, cough, diarrhea sometimes, respiratory distress, sore throat and rhinorrhea. Apart from acute respiratory distress syndrome, we are familiar with cytokine storm and a plethora of systemic manifestation, among others include acute conjunctivitis. What is the pathophysiology of the eye infection like? Coronavirus has been previously reported to cause conjunctivitis in human, but rare and mild. Angiotensin-converting enzyme 2 receptors play important role acting as COVID-19 entry receptors to the lungs and various other organs in the body. ACE2 receptors have been detected in human conjunctival epithelium as well, cornea, retina, retinal pigment epithelium, and choroid. Wu et al. Reported that 1/3 of his COVID-19 study population had ocular manifestation, of which 16.7% had positive result from both conjunctival swab as well as the nasopharyngeal swab for COVID-19. Findings suggest low prevalence of COVID-19 nucleotide in tears. However, similar findings were also observed in SARS coronavirus 1. Meanwhile, Chen et al. Reported a 30-year-old man confirmed COVID-19 patient with bilateral conjunctivitis on day 13 of illness. Conjunctival swab was positive on day 14 of illness. Illness resolved on day 19, the day his conjunctival swab became negative. The case suggested viral load in conjunctival specimen gradually decreased over time, probably of less possibility of transmission. This slide shows resolution of conjunctivitis from day 13 to day 19. Question often asked, can the tears transmit COVID-19 infection? It remains unclear how COVID-19 virus accumulate in the ocular secretion. Is it retrograde from the nasopharynx? Colavita et al. Presented the first confirmed case of COVID-19 in Italy. A 65-year-old Italian lady who traveled from Wuhan to Italy presented with URTI and bilateral conjunctivitis on day 2 of illness. Her conjunctival swab were positive for COVID-19 on day 3 through to day 21. What did the clinical presentation like? It's just like any other viral infection. Like most viral conjunctivitis, COVID-19 conjunctivitis is self-limiting, resolving in 14 to 30 days. So far, there is no reported cases of sight-threatening complication, such as scarring and blurring of vision, though there is a case of keratoconjunctivitis reported. Treatment involved the use of frequent preservative-free artificial tears with topical antihistamine to relieve the itchiness, topical antibiotic to treat secondary bacterial infection, and cold compress to provide comfort. Dicroadenitis is the inflammation of the lacrimal gland. Monica et al. Reported a 22-year-old man, previously fit and healthy, confirmed to have COVID-19. He presented with dicroadenitis associated with orbital inflammation, which progressed to ophthalmoplegia and preceptor cellulitis as shown in the CT scan on the right. He responded well to corticosteroid treatment. Orbital inflammatory disease may potentially occur in COVID-19 due to infectious process itself or immunological response. However, the causal relationship remains uncertain. Next is the episcleritis, which is the inflammation of the episclera and the vascular tissue. It can be diffuse in nature or it can be nodular. Most likely it is caused by immunovascular factor and or coagulation disorder or vascular thromboembolism. Inflammation of the uval tissue gives rise to anterior uveitis. Whether it is in isolation or in association with COVID-19 related multi-system inflammatory disease. Retinal abnormalities were observed in severe COVID-19 patients. These include venous dilatation, vascular tortuosity, retinal hemorrhages, as well as soft exudate or cotton wool spot. These lesions were postulated to be due to direct inflammatory infiltration of the retina or microangiopathic disease from the viral infection. Several neuro-ophthalmological manifestations of COVID-19 have been observed. Central nervous system complications of COVID-19 are caused most probably by immune and inflammatory responses, the coronavirus itself, or the vascular thromboembolism causing stroke. Cranial nerve palsy involving the third nerve, the fourth nerve, and the sixth nerve associated with COVID-19 have been reported within a few days of fever and cough, most without remarkable radiological finding. Next is the post-COVID-19 optic neuritis, seen in an older patient with COVID-19, presented with blurring of vision and scotoma. Another manifestation is acute cerebrovascular events in relatively young patients, which lead to stroke affecting the visual cortex, and this can complicate the course of the COVID-19 disease. Last but not least is Miller-Fisher syndrome, which is a polyneuritis cranialis, where there is demyelination causing ophthalmoplegia, ataxia, as well as aplexia. Let me end my presentation with the message that ocular shedding of SARS coronavirus 2 via tears and ocular secretion is a distinct possibility. Conjunctivitis and episcleritis can be the first presentation and even sole manifestation in patients with a COVID-19 infection. And SARS coronavirus 2 may trigger or exacerbate inflammatory and demyelinating disease. Large and long-term studies are needed as the SARS coronavirus 2 evolve. I thank you for your attention and stay safe, everyone.
Thank you, speaker. From this, I believe that it is very crucial for everyone to create and share more awareness on COVID-19. Without further ado, we will continue with the Q&A session. Please welcome the judges.
Do we have local studies about incident of eye involvement in COVID-19? Because all these are external source, yeah.
Yeah, so far nobody has reported. Everybody is so overwhelmed with the systemic disorder. So if there are cases also, it's not been reported yet that I know the answer.
Yes, I think probably should alarm.
The only thing I know is that it changes, the ophthalmology practice, and because ophthalmology like ENT, dentistry, and all that very close proximity with the patient. So it changes in the sense that they put a shield, and then of course they have to wear the attire.
Thank you, Prof, for the enlightening presentation regarding clinical cases that you have presented. Now, Prof, I always have children in my mind because I'm a mother now. I would like to ask if children who are infected with SARS-CoV-2 coronavirus 2 and they end up with conjunctivitis, how would we then help the children to stop rubbing their eyes probably, or what should be done, at the bedside?
Regarding the conjunctivitis in a child, so to provide as much comfort as possible, cold compress, antihistamine, and prevent them from rubbing. And of course, it's very difficult. It's very difficult. It can be very, because the presence of the virus particle in the tears, it can be transmitted actually through touching to others. It's just like any other viral conjunctivitis actually. It can spread very easily. So there's no study to show that it can very transmit.
Thank you, Prof.
Alright, thank you judges and speaker for the very active session. As all presenter has presented, the marking sheets will be collected once the session ends. So for the judges, please finish your scoring and comments. With this, I conclude that today's session has come to an end. I believe our audience was intrigued and captivated by all presentations just now. Hopefully, the presentation will be beneficial for all of us. Thank you to the judges and speakers for the excellence and insightful session.